Good morning, everyone. I'm also presenting some findings that are related to equity, this time in relation to the expansion of GetCheckedOnline. So the context for this study was, as Heather was describing earlier, the higher increase of or reach of GetCheckedOnline here in BC. And based on one of the studies that was included in this grant. So the community SDA testing survey was done between July and September of 2022. It had online and in-person recruitment with mixed venue-based and network-based sampling. And it was conducted in these communities that you see here. So Greater Victoria, Maple Ridge, Kamloops, Kimberley, and Nelson, as the sites that had GetCheckedOnline reached to them outside Vancouver. So for participating in this survey, people were residents of British Columbia, at least 16 years of age, sexually active, defined as having at least one sexual partner in the last year, and able to complete the survey in English. So I worked with this survey, and for this particular project, we had two general objectives. So one was to describe awareness, use, and intention to use of GetCheckedOnline in these 5 urban, suburban, and rural communities. And we also wanted to examine associations between these, between awareness and use in a specific, with socio-demographic characteristics with a health equity lens in mind. So here is again the same theoretical framework that Muyi was presenting. I just want to show this to emphasize that this framework poses more importance in the social processes that generate inequities in power and privilege. So we use identity labels just as markers of social locations. And then we are interested in how that has an impact in awareness and use of GetCheckedOnline as a health promoting resource. So for our analysis, we had reach and use as primary. The variables that we used to describe the social location were age, gender identity, sexual identity, race, ethnicity, educational attainment, and income. So for this study, I use logistic regression modeling. This framework also informed what was our approach with for model building and purposefully isolating the effect of each variable. So we had over 1,600 total participants with a sample with a high proportion of individuals who experience increased barriers to provider-based testing. So about 60% of our sample referred having experienced at least one barrier to provider-based testing. Also, other highlights of the sample, over half identified within the 2S LGBTQIA community, and we also had about 12% of our participants identifying as Indigenous. So awareness was about 1 in 3 in the overall sample. About half of those who were referred that they had used the service before. That corresponded to about 1 in 5 people in the overall sample. And among those who were not aware of the service before the survey, about half of them said they were very likely or likely to use the service. Now, I will show you quick overview of the results for awareness and use. So for all these slides, awareness is in green and use is in yellow. So for age, we observed that the people with in the younger and older quartiles of our sample showed significantly lower odds of awareness and use. And we saw also some similar pattern for awareness for the third quartile. Um, for race and ethnicity, so we observed that people of color that included a large group of people with different identities from among a list. Both awareness and use were higher, and for indigenous folks, we observed higher awareness, but not necessarily higher use. Gender identity was analyzed in more than one dimension. So we defined a first dimension here comparing people identifying only as men to those identifying only as women. And then this group including people identifying as gender fluid, gender queer, agender, non-binary, and people also who referred having multiple gender identities. So in this comparison, we noticed that this third group had higher awareness in use, whereas women had similar awareness but lower use. Another dimension was this comparison between cisgender and transgender participants. So here also we observe a pattern of higher awareness in use for trans people. And in a similar fashion, when we identified or analyzed sexual identity as another marker compared to those identifying strictly as heterosexual, those in the LGBT plus group also had higher awareness in use of GetCheckedOnline. And when we grouped the 2S LGBTQIA plus group, this was one of the strongest associations we found in this study. Um, for education, we did not find any significant difference that was of relevance in the framework that we were using to identify inequities. But for income, we observed this clear gradient of awareness and gradient of use related to people's reported income. So you see here that groups with lower income report lower awareness in use, and the difference is very significant or strongly associated with the lowest income group. And we also found a difference for the second income group and use. So here we are observing a unique pattern of distribution of awareness and use in this sample related to GetCheckedOnline. We were interested in describing more of this pattern because we know from the literature that every service has its own unique context and shows different patterns of use. And some of these patterns followed a social gradient or an expected effect, as we saw for income and age. And we saw this complex pattern not aligned with social gradients for gender and sexual identity and race and ethnicity. So we have reflected on these findings from using two concepts of a framework that is related to the diffusion of innovations. One of them is relative advantage. So it is this perceived advantage that people would create by comparing the options they have. So in this case, it would be comparing GetCheckedOnline to provider-based testing. And using this framework, we emphasized how this comparison is strongly shaped by individual social circumstances. So, for example, some elements of safety or concerns with the safety of the healthcare system could help some folks avoid the healthcare system or avoid contact with providers by using GetCheckedOnline. It can also help avoid bad experiences related to STBBI stigma. However, there are other needs that may be appearing in place here. So, for example, GetCheckedOnline does not offer or is not connected to HPV testing, access to contraception, PrEP, or vaccines. Also, as we have reflected with the other findings, there might be technology barriers. And the system also relies still in the, or GetCheckedOnline as a service still relies on the healthcare system. For example, with the lab partners that might not be reflecting the same approach to how they provide service to people. And then another concept of communication networks, this has been important to think about promotion strategies. So in this framework, there's this concept of homophilous communication that happens between people that perceive themselves similar compared to heterophilous communication that occurs when people perceive themselves different than the people that they are interacting with. So in this case, we observed with using other information coming from the same survey that friends were consistently the main source of communication about GetCheckedOnline, but also healthcare practitioners were on the other side the most common source when thinking about connections that are not personal relationships, so, such as friendships or family members. So there are also here elements to consider about communications such as STBBI stigma, or what guides or limits are we providing to healthcare practitioners to promote the service. So the findings have had implications for GetCheckedOnline. We also have reflected on how the community participation in the design of GetCheckedOnline at several stages might have contributed to designing a service that is appealing to certain groups. We can also think about how improving relative advantage could be a promotion strategy, as people tend to talk more about things they want people to know about things that work for them. So it could be like an indirect strategy for promotion. We saw that there could be some elements of universal proportionality or improvement of health equity through GetCheckedOnline by reaching groups that experience increased barriers for provider-based testing. And lastly, there's also a reflection about how service adaptations are a response to broader systemic and structural factors, and how sometimes relatively simpler changes can help us address these undesired inequities with the service. So with that, yes, I think I'll pass it on to Mark again.